Assalamu alaikum wa rahmatullah. Today we're going to start our meeting. So Dr. Suleman and his team will be presenting. Here's the agenda for today. Dr. Suleman, when you are ready, please go ahead and start the meeting and you can moderate. Thank you.
Okay, thank you, Dr. Nadin. Hello, everyone. My name is Suleman Elhoweris. I'm the Green 2 group leader, and today we are going to present to you some interesting topics, hopefully, to you guys. And it's a pleasure to be here among successful people in this group, and inshallah, we're gonna do our best. Before we go into that, I would like to thank Dr. Nader for the opportunities that he's giving us. Thank you, Dr. Nader, for like all of these opportunities and the chances, and like giving us the chance to grow within the TGRF and Michigan State University Fellowship of Research. We are very grateful for that. So today we are going to start with multimorbid conditions, and the presenter is going to be Lena Abdelhadi. Thank you.
Thank you, Dr. Suleman. Thank you, Dr. Nader, for this opportunity. I'm glad to be here today. Just let me know if you guys can can see my screen. Okay.
Yes, we can see Lena.
Okay. So I will start the presentation now. Sorry if my voice is a bit cracky. I'm just recovering from a viral illness. So my presentation today will be about multi-comorbidity. Okay, let me share. The objectives for today's presentation, first to discuss the definition of multimorbidity and the associated risk, and know why most clinical practice guidelines are not appropriate for older adults with multimorbidity, and the 5 guiding principles for evaluating older adults with multimorbidity and managing their care, and the challenges the clinicians must try to overcome when caring for older adults with multimorbidity. First, we will start with the definition. Multimorbidity means the occurrence of 2 or more chronic medical or psychiatric conditions. It's really important to include these psychiatric conditions as well, because as we know that older patients suffer from have a lot of more risk for depression and other psychiatric condition, which may or may not directly interact with each other. The term multimorbidity differs from comorbidity, which sometimes physicians use as the same, but comorbidity indicates a condition or conditions that coexist in the context of an index disease. The term multiple chronic condition can be used is a closely related term to multimorbidity. As we know, multimorbidity is strongly associated with age, and the prevalence increases among those age 65 or older. The impact, it's associated with increased risk of death, functional limitation, disability, adverse treatment effects, hospitalizations, use of healthcare resources. As we know, there could be repeated emergency care visits and even nursing home placement, and of course, decreased quality of life. These are just to mention a few. So the first point, we're just going to discuss the patient care challenges and why it's so difficult to approach patients with multimorbidity. First, we have limitations of disease-focused approach. I'm going to go through each of these by itself. Adherence to multiple clinical practice guidelines, competing demands and shifting priorities, polypharmacy, and limited evidence. First, limitations of disease-focused approach. So basically, most treatments and guidelines, they target a single index condition, but patients with multimorbidity are complex and heterogeneous. So basically, older patients are heterogeneous when it comes to the illness severity, functional status, prognosis, and even adverse effects. So it's really important to put this into mind. Overlapping treatments can cause clinically relevant challenges. For example, an elderly patient with dementia could be prescribed donepezil, which is a cholinesterase inhibitor, to improve their cognitive function. However, the same patient might experience urinary incontinence and go to a different provider, which prescribes oxybutyrin, which is an anticholinergic medication. So basically, the same patient is receiving two different medications. This is what I mean with overlapping treatments. Another common problem is therapeutic competition, which means that a medication prescribed for one condition actually could be harmful or exacerbating for another condition, as I just mentioned. The second point or the second challenge is adherence to multiple clinical guidelines. Most clinical practice guidelines are developed with the intent to address a single diagnosis or a single management in a single clinical entity. So this is where it's challenging because we're dealing with patients with different conditions. There is a need to adapt recommendations and guidelines for patients with multiple comorbidities. And recently, we've seen this happening when the American Geriatric Society and the American Diabetes Association, they came up with recommendation for the management of older patients with diabetes, which basically advocate for prioritization of goals of care among multiple conditions and put like certain glycemic targets and blood pressure control target among patients with limited life expectancy. The key in prioritizing among multiple guidelines is understanding what matters most to the patient and the time horizon to benefit. Basically, time horizon to benefit is how long it will take until the benefits of an interventions are achieved, because sometimes we're dealing with patients with limited life expectancy. The third challenge is competing demands and shifting priorities. To maximize the quality of life, patients with multimorbidity must achieve a balance between attending to their health problems while maintaining control over their daily lives. So basically, sometimes clinician with well intent can aggressively attempt to treat all the conditions that the patient is suffering from without sufficient attention to the whole person. And this might result in treatment recommendation that the patient finds overwhelming, unaffordable, or otherwise even unrealistic. So it's really important to look at the patient as a whole and know what their expectations and what their goals of treatments are. And for them also, it's not that about treating their condition, it's also about them being able to maintain control over their daily lives. The fourth challenge is polypharmacy. Excuse me. Patients with multiple chronic conditions take more medicines and are at greater risk of being prescribed potentially inappropriate medications. Plus, it's associated with the burden of cost and risk of drug or drug condition interactions. And that's something we see a lot with multimorbidity and geriatric patients. The fifth challenge is limited evidence. Patients with multimorbidity are underrepresented in clinical research population due to a challenge of recruitment and retention that leads to selection bias. So, plus we have the heterogeneous nature of multimorbidity. It makes it really difficult to control for confounding or draw inference about how a broad array of coexisting conditions may have impacted treatment effects. So basically, they're not favorable for researchers. So the next point I'm going to talk about is I'm going to discuss an approach to evaluate and manage patients with multimorbidity. These are the key points or key approach points to evaluate them. First, elicit patient goals and priorities, coordination of care, less may be best. We will discuss each of them, and identify and address issues that impact multiple conditions. And we have common disease-specific considerations like hypertension and diabetes. So this is those steps in more details. First, inquire about the patient's primary concern, and if possible or if applicable, also involve family and friends. And any additional objectives for the visit. So you start basically by knowing the patient's primary concerns and their objectives for the visit. Then second, conduct a complete review of care plan for a person with comorbidity, multimorbidity, or focus on specific aspect of care for a person with multimorbidity. Third point is know or ask questions like what are the current medical conditions and the current interventions the patient is having? And is there any adherence, comfort with the treatment plan? Is the patient happy? The patient is not happy? He's facing any problems with his current treatment plan? Fourth, consider patient preference. As we said, patient preference play an important role in evaluating and management. Fifth is relevant evidence available regarding important outcomes? Consider the prognosis. As we said, we also face the factor of sometimes having patients with limited life expectancy, so it's really important we address that as well. And consider interactions within and among treatments and conditions. We said that. Weigh benefits and harms of components of the treatment plans, and communicate and decide for or against implementation or continuation of intervention or treatment. And reassess at regular intervals for the benefits, feasibility, adherence, alignment, and patient's preference. So it's really important to reassess at each of these steps just to make sure that we're going according to the patient's plan. So I will go in a bit of detail. First, we said elicit patient goals and priority. To optimize care for the individual patient, a provider must understand the patient's goals and preference and how their health relates to perceived roles within a family or community. So basically, it's really important to also know the patient's expectations from the treatment, the patient's expectations regarding their quality of life. So to avoid any, let's say, disappointments and any unrealistic expectations. The discussion about patients' goals and priorities include medical decision-making to include drug initiation and discontinuation, of course, hospitalization, procedures, receipts of preventive service, and recommendations for behavioral changes. So the discussion about the patient's goals should include basically every aspect, not just like the medical decision, but everything involved in the patient's care. The second is coordination of care. Patients with multimorbidity experience frequent clinical encounters, often with multiple providers, in addition to inconsistent recommendations or duplicative care from various providers. As I already gave an example for this, like patients could be receiving 2 different drugs for 2 different conditions from 2 different providers. And this can result basically in patient confusion, unnecessary cost, and treatment burden, resulting in poor quality of life. So integrated care involving both psychiatric and medical specialty providers to address the medical condition and depression can improve the quality of life and disability outcomes. So when it's feasible for physicians to maybe organize a multidisciplinary team approach, which involve basically every physician or a nurse involved in the patient's care just to coordinate the care and the treatment plan given to the patient. So just to try to improve the quality of life and basically avoid patient confusion and unnecessary cost. Less may be best. So what we mean is we will discuss it in 3 aspects. First, treatment goals. Careful consideration should be given to each treatment decision because, as we said, sometimes for patients with limited life expectancy, for example, the glycemic control will be different from a normal patient or patient without multi-comorbidity. So treatment goals differ basically in patients with multimorbidity, so we have to address that. Cancer screening. Preventive practices such as cancer screening should remain relevant and appropriate for patients with multiple chronic conditions. Cancer screening in patients with limited life expectancy is associated with unfavorable risk to benefit ratios. So as we said, sometimes clinicians are just aggressive in their management, they're aggressive in their screening. So we have to put that into mind. Medication consideration, as I talked about the concept of time to benefit, it's important to consider the relation to drug prescribing for patients who have multiple comorbidities and may also have limited life expectancy. The third basically approach is to identify and address issues that impact multiple conditions. And these are just issues that I'm not going to go over all of them, but these are just to list a few. We have nutrition, physical activity and exercise, functional independence, sleep disturbance, mental health, safety of environment and adequacy of support in current level of care, social risks as well, and caregiver stress. So it's really important to address all these issues just to decrease the burden on the patient. As I said, we have common disease-specific considerations. These are the ones that are studied the most, basically, diabetes and hypertension. So for diabetes, the appropriate target for hemoglobin A1C should be individualized based on life expectancy and comorbidity burden. A target of 8% is appropriate in persons with limited life expectancy or persons in whom the risk of hypoglycemia outweigh the benefit of more aggressive treatment. The risk of hypoglycemia is increased in older patients. So when possible, therapeutic agents that have a lower risk of hypoglycemia should be selected. Insulin therapy may be inappropriate in patients with cognitive or visual impairment due to increased risk of medication error, unless the patient has a caregiver to assist them with the insulin doses. Electrolytes and renal function should be assessed within 1 to 2 weeks of initiation or dose adjustments of ACE inhibitors, ARPs, or diuretics due to increased likelihood of adverse effects in patients with multimorbidity. For hypertension, a less aggressive systolic goal blood pressure may be appropriate for patients with limited life expectancy. All patients should receive non-pharmacological therapy, particularly dietary salt restriction, weight loss in obese patients, blood pressure, weight loss in obese patients specifically. Blood pressure should be reduced gradually. Comorbidities should guide the choice of agent with the goal to avoid exacerbating comorbid conditions. So basically, because these are studied the most, we have like a specific consideration when it comes to patients with multimorbidity. So we need more research, we need more guidelines for other conditions. Okay, so I have a question at the end. I will just read the case a little bit slowly. We have an 85-year-old man comes to the office to discuss treatment options related to a recently diagnosed aortic stenosis. He lives alone with the support of his daughter since his wife died 3 years ago. He's short of breath with minimal activity and has been hospitalized twice in the past 3 months for heart failure. He does not have classic symptoms of angina. He says that he would rather die than live as he has for the past few months. He has told his daughter how he feels. History: he suffers from diabetes, osteoarthritis, prostate cancer, which responded to hormone therapy, and no significant change in PSA level over the past 3 years. Medications: he's on lisinopril, spironolactone, beta blocker, and increased dosage of diuretics. He remains symptomatic despite the aggressive treatment. Echo findings: ejection fraction of 62%, aortic valve area of 0.6, and mean transvalvular pressure gradient of 41. Results from a nuclear stress test done 1 year ago were normal. Consultation with the intervention cardiologist told him that he may be a candidate for transcatheter aortic valve replacement, which is TAVR, but had concerns about his age and comorbidities. So which one of the following is the most appropriate next step? Is it to discuss the benefit of hospice or increase diuretic dosage or call cardiology or ask if the daughter can be involved in the TAVR discussion? So if anyone's been following and will wish to answer.
Eh?
Sorry?
Eh?
It's actually not A.
I think
Because I said the
it's
most appropriate next step.
I think ask the daughter, right?
Yes, that's actually correct because we're talking about the most appropriate next step. As I mentioned in the presentation, um, that it's really important to start when we are addressing patients with multimorbidity. It's important to elicit the patient's goal and understanding of their condition, as well as the expectations from treatment. And if possible, it's really important to share the decision with, if applicable, to share the decision with family members, with friends, if possible, just to make sure that the patient does not have any unrealistic expectation, because as we know that TAVR comes with a risk. And basically all of these are, they're not wrong. After you discuss with the daughter and you discuss with the patient, it's okay to call cardiology, of course. You can discuss the benefit of hospice if the patient's refused. But it's really important to involve the patient and to start with the patient understanding. So basically, if anyone has any questions, I will be really happy to answer.
I think no question. Dr. Nader, do you have any comment or something?
Thank you so much, Dr. Lena. This is a great presentation. Yeah, just remember that as we get older, or as you see your patients who are older, sometimes comorbid conditions will come, and sometimes you might have a patient with two problems at the same time that you need some guidance as far as balancing. One of the cases I see common is patients with GI hemorrhage, for example, or bleed, who are also have AFib on anticoagulation. So which way you want to do? You want to continue anticoagulation? You want to stop it because of GI bleed? So in these cases, you want to discuss with the patient the benefit and the risk. Also, you may need guidance from the cardiologist and GI specialist to see what their input, what they think is the best way to help the patient. Another case is heart failure and kidney failure or kidney problems. So you put patient on diuretics, Lasix, for example, and they have problems with their kidneys. So you want to balance that. You want to get them asymptomatic, but at the same time, you don't want to harm the kidneys. So you may need to also get an input from a cardiologist and input from the nephrologist. So just put in mind that some places, some areas, some patients, you may not be the only one who make the decision. In the case that was presented, you want to involve the patient, their family members in this case, to help them guide you which direction they want you to take. And the same way, if you want to get an input from a specialist or more than one specialist to help your decision making and your patient's decision making, just think about getting this input and then what's the best for the patient. Just to remind you in the future, sometimes you might have some complicated case. Because realistically, at the medical school, we were taught and we teach medical students that patient with heart failure, you need to do this, but we don't tell them what if the patient also has renal failure, what to do. So just to keep in mind. Thank you.
Thank you, Dr.
Thank
Nadir. I
you.
really agree because it's very challenging when you're managing patients with multimorbidity. And the guidelines, as you said, are most of them are just intent for a single disease. So thank you so much for your input.
I appreciate it. Thank you,
Thank-
Dr. Lena. Go ahead, Dr.
Thank you
Suleman.
very much, Dr. Nader and Dr. Lena. Now it's going to be my presentation. Lena, if you could open Teachback. Yes. So, today I'm going to talk about decision making in healthcare. But what is decision making on a daily life basis? Like every day we choose like what movie to watch, what food to eat. Every decision that we make in our lives goes through a process in our minds. And I'm going to explain to you specifically in healthcare when we decide to do any management, for example, we do go through specific processes in our minds. And decision making in healthcare is a key component for practicing medicine and for caring of patients, right? So, so there are two types of decisions that decision making processes that we do. There is an automatic decision making and there is an analytic decision making. So what is an automatic decision making? Let's say, for example, I go every day to the university and I go through a specific road and I know the area very well. So I'm driving to my university and then let's say an accident happened wherever. This process is I every day go to university with the same road, and I go with my automatic pilot to the university, and then this car crash happens suddenly, meaning I'll change out of my automatic decision, my normal everyday, decision of going through this pathway. But then automatically, because I know the area well, I'll go through another route to reach my university. So automatic decision making is matching the patterns based on previous knowledge and experience. So I have an experience going to other places other than my university. That's why I know there is like other roads, like as we say, all roads leads to Rome. So I'll take another pathway to reach the university. So this is an automatic decision. I chose it because I have experience with the road. I have an experience with going with other routes, and then this is what we call an automatic decision making. The other way around, there is an analytic decision making which we use mostly in medicine. It's based on available time and information, and we consider our options, and we do gain more details and reach a reasonable choice. So out of medicine, maybe for example choosing a new car. When I want to go and when I go to the dealership, I would know automatically. Let's integrate the automatic decision making. I know how to reach the dealership car place. So I know which road to take. I know how to drive the car. Automatically, I make all the decisions to drive my car, reach the place. But once I'm there and I'm choosing which car to buy, then I'll be using my analytical decision making. Now I'm looking, how much is the car? Is it worth? Is it worth it? How much will I pay if the car gets like it need like a new tire? You know, this is when we do more analyzing of the situation. We analyze the car. We do more thinking with our brains to reach for a decision. So this is what's analytic decision making is. In medicine, there is a lot of examples that we're going through, and we're gonna see in the other slides. So the problem with decision making that there are some mistakes and some stuff that could go wrong, and this may be choosing a wrong option. As I said, maybe you choose an expensive car because you like how it looks, but then because you have a specific budget, then you will have a problem with, okay, the tire is flat, I need to change it. How much is it? Maybe it worth quarter of the money that I paid for the car, and I'm not that my budget is not that high. So choosing a wrong option might be a problem when you do decision making. Other problems are failing to decide when most needed. What is the priority to me, right? And then correct but delayed decision. Some people get in the process of thinking, they take too much time to reach their decision, and then this would lead to an outcome that we don't need, right? And then this is what we see in medicine most of the time. Maybe a doctor is trying to do extra investigation to reach out for, and to exclude another diagnosis, and then it's going to be a problem for the patient if it's an acute disease like MI or a stroke, right? And then the last thing is fail to decide that at all and continuing with the disaster. So sometimes we do choose some wrong decisions and would lead us to some bias, and then I'll still be like, oh, maybe I have to do this and I have to do this, and do like proceeding further within my mistake. So these are the problems that we face with decision making. So I'll go more into analytic decision making because it's more what happens within the practice of medicine more than automatic decision making. So analytic decision making, we have a sequence of events that goes through in our minds. There is step 0, which is decision trigger. When a decision comes to you're like in a situation awareness, we have a patient coming, okay, and they are maybe a patient of an asthma having an acute asthma attack. When the patient comes to you within the situation awareness, you would know if the situation is like acute or severe or moderate or mild, right? So this is where the analytic decision would start, when maybe you are facing something out of your experience, or you're facing something you would think it's severe. I need to do more analysis, and I wouldn't go through automatic decision making. So within the analytic decision making, we have decision trigger, which is step 0, and then we go to assessment. After assessment, we do, sorry, go back, Lena. We have assessment, option checks, projection, and review. So we start with assessment. Assessment, the principle is asking the right question, prioritize the important features. For example, if there is a patient who needs an appendectomy, we would look for the specific reasons to refer the patient for active surgical management to do an open appendectomy or a laparoscopic one, right? So we would look if the patient have, for example, rebound peritonism, or will they have like a dry, uncoated tongue, maybe like sepsis or like high fever, all of these stuff. You would go through a list in your brain while thinking you're assessing if the patient actually needs the appendectomy or not. And the errors that would happen, that we hurry to first available option, or we might even fail to realize the main objective of our plan. Are we here to improve compliance or curing the disease? So the assessment, the first stage of analytical system, analytical process, is assessing the the situation so that we can go to the next step. So after assessment, we do the option checks. Identify the ultimate objectives and options. We need to know what are we trying to do. We want to do an appendectomy. Okay, so what options do we have? So we need to step back to see if any other options that have yet not been considered. Uh, is this an appendicitis or something else? We need to look for other options. Okay, we want to do an appendectomy. Is it better to do an laparoscopic one or an open appendicectomy? So we need to decide within our analytical part of our brains and decide. So necessity is very important in option checking, as when no existing option looks attractive, as the example was, there is a patient, there was some specific doctor was in a plane, a patient was previously, there was like a passenger within the train, within the plane. Before he got into the train, he was in an active accident, but he still got into the plane, and then suddenly he started to collapse. So the doctor within the plane came and tried to assess the patient and look for the problem, and then he realized that now this is where decision making comes. He was trying to look what is the problem is. He did his examination. He found out that the patient had some diminished airway, diminished chest, diminished air entry within the auscultation of the chest, and he found like there was resonant percussion, and then he knew that it might be pneumothorax. And then there was like a junior doctor with him. He asked him, well, what do you think? The junior doctor did his own decision making, and then they both agreed that this is a pneumothorax. So what can we do while we are on like 8,000 above above the ground? What are we going to do? We needed to do a chest drain. Then they were looking for options. What can we do at the moment? So they decided to use a catheter, a urinary catheter, a some type of pure alcohol for sterilization. They also used like some water bottles to make a one-way valve. This is the necessity, as they say. Necessity is the mother of invention, right? So they decided, they made an assessment. Okay, the patient has, this is the analytical part, huh? They made an assessment. They found that the patient has pneumothorax. Okay, what are the options that we have? They tried to call the local authorities. They said we can't do anything, and if they were any minute late, the patient is going to die. So they decided to proceed with the to make a chest drain using urinary catheter and a one-way valve using water and alcohol. So this is the option checks. And necessity would make you get with the better, would make you have like um an outlook to see what's going on, what can I do, and then you will come out with a solution. So next after the option checks is projection. Predicting the consequences for each potential option, gathering data over time to make projections as accurate as possible, and choose the best one after comparing the predicted outcomes. And this is what the example that I gave, they did. They were like, what can we do? What are we going to do? There's we can't reach to the closest hospital. The plane can't land because they were like above, I guess, the sea or something. So they had no other option other than making a one-way valve using the making a chest drain with a one-way valve within the plane. So this is the projection part, and then we will go to revisiting the decision based on new updated information. And updated info can be used to suggest new options and update the projections. And these are for yeah just to get more information as part of the analysis, so that next time whenever you are having, and this is how experiences is, whenever you get into a specific situation, you will build experience, and within this experience you will go and get more information, and then you will have an extra experience, so that you will, within the review, you will grow eventually, right? So this is the review, and then we have another topic, which is teach back. Teachback, as we know, is a tool to confirm that the patient understands what you have explained to him. And teachback helps reduce readmissions, improve patient experiences, and increase patient comprehension. All of these are also key components within in medicine and practice in medicine. Um, uh, this is within this was the last one, so you can go to the next. So enhancing communication. Enhancing communication. This is the teachback. Teachback enhances communication, and there is some guidelines or criteria that's called enhancing communication, a powerful communication technique developed by the Agency for the Healthcare Research and Quality. Support the Healthy People 2030 goal of improved communication between patients and health professionals, and it was designed to enhance communication skills and foster a patient-centered approach that promotes understanding and informed decision making. Next. So the benefits of teachback is that it's authentic and time saving. We don't need any, like we don't need the patients to be um, you know, not understanding what's going on. You need to make sure that the patient understands every and each plan or specific plan that you made for them. Without that, the patient would go back home and do some kind of mistake. Maybe you told him, come, you have to call the GP and meet him within the next 5 days. If you are doing well or not, then the patient might perceive it as, okay, if I'm not well, I have to call the GP, and then this is a problem, right? So when and where do we do teach back, specifically and more importantly within discharge? Also patient education, new diagnosis, clinic visits, and plan of care. All of these sets are were really important to do teach back for the patients. Next. So how do we do teach back? Okay, so we do focus on my explanation as a physician, not the patient's memory. You need to make sure that the patient gets with gets the idea, and like you don't need to say that, okay, I did tell the patient about that. He need to know it by now, but we wouldn't know what is the situation going on with the patient, right? So, and we also need to avoid close-ended questions. Do you understand? The patient would feel pressured. Yes, I understand, as such questions would lead to some, you know, um, inconveniences and so on, and also practical phrasing. I know we covered a lot of information. Can you tell me what you heard? So after you finish the patient, told the patient, okay, we are sending you back for a migraine, let's say a migraine management. Okay, you need to take propranolol every day, and whenever you're having an attack of migraine, you do take um, you do take cimetriptan and all of the stuff of migraine drugs. And then you have to tell him that, I know we covered a lot of information. Can you tell me what you had? And then this is the teach back. This is the core of teach back. And when you get home, how many times a day are you going to take your medication? You need to be more specific after you told him the specifics of your plan. Next. So the teach back method, as we said, it's a developed method. Starts with chunk and check, non-shaming, plain language, avoid yes or no questions, and closing the loop. And all of these teach back messages is designed to enhance communication skills. So we will be focusing more on plain language. Next. So as I said, techniques start with the chunk and check, non-shaming, plain language, avoiding yes or no questions, and closing the loop. So what is plain language in healthcare? So we do limit the use of medical jargon, non-essential words, non-needy words, using language that patients are familiar with outside of a healthcare setting, and regularly check in with the patients to assess their understanding. Next. So the jargon trap, the failure. Providers approach using complex medical terminology. Maybe a patient we are using, okay, you, as you know, you came to us complaining of a GI internal bleed and also medications. All of these words are not might not be understandable for the patient, and also the patient's reactions. The patient becomes increasingly stressed and confused by the term, stating, don't know what much of that means, but okay, I guess. So the result, lack of patient engagement and understanding. And this is what I might say is an anti-communication. So the patient needs to understand everything, right? So we don't need to use any jargon information, any medical terms. So the success, effective communication using plain language. So with using plain language, we do build rapport, translating the jargons, and patient engagement. By using these, the result is the patient is fully understands the diagnosis and agrees with the plan. Sounds like a plan. That's what most of the patients say. And then the outcome is more than this, is that the patient is going to follow your plan, and we would reduce the readmission rates, we reduce the medication problems on all of the side effects. Next. So to end, empowering patients through communication, learning about the patient, using plain language, and connecting technical information to a patient's life experience. So again, the barriers that most of the physicians do face with teachback is that the time constraints and the awkwardness, putting the patient at the spot. Some patients feel a bit awkward, but we have to build a better rapport, and we need to give much more time for this issue, and hopefully all the setbacks would be, we would be dealt with. So that's for the teachback. Then the next topic is vaccine hesitancy. So what is the problem with vaccines these days is that what is the hesitancy? Spectrum ranging from simple uncertainty to firm refusal, maybe a delay in acceptance or refusal of vaccine despite availability. This is the challenge that we are facing as physicians with patients who are hesitant or against the vaccines. So how are we going to? What drives it? Confidence, mistrust in safety, efficacy of vaccine, and mistrust in the system itself. Com- uh, Complacency, low perceived risk of disease, it won't get to me, and convenience, accessibility, cost, and location. All of these drives the vaccine hesitancy. Next. So also fluid of misinformation. Hesitancy is often fueled by a mix of misinformation and disinformation. Misinformation is a false info spread unintentionally, for example, misunderstanding a study or like the news, and disinformation, false info spread intentionally to deceive, propaganda. This creates confusion and erodes trust in experts and within the medical field. Next. So what can we do? We need to build more trust, and by not winning an argument, we need to build a more trust and rapport with the patients. Next. So we need to listen to understand and not to reply. Don't just wait for your turn to talk. Hear their actual concern, fear, mistrust, or confusion. We need to, understand what the patient is. Why is the patient trying to, or why is the patient actually hesitant? And we need to listen and understand and be open and ask open-ended questions. What are your main concerns? What have you heard? And avoid yes/no questions. Next. Acknowledge and emphasize. You don't have to agree, but you must validate the patient feelings. It makes sense to have questions. Everyone have questions. Be present. Give them your full attention. The goal is not to win an argument, but to build a bridge of trust. Next. By using all of these, we would, hopefully get over the vaccine hesitancy, and not only vaccines, but most of the medical management that patient would not agree with the providers that they would need. And using all of these steps would be really strong and really good way to deal with the patients. So can you open the decision making, Lena? Sorry for taking much time, but this is the last one. So we are going to go through informed consent. So what is an informed consent? Informed consent is signing is gaining rights. Informed consent is a right for the patient. Is a patient is not signing away their rights. They are gaining rights and protection by using a a consent. Specific rights include the right to privacy, the right to ask questions as the clinical trial moves forward, and negligence protection. The document does not require a patient to give up their legal right to protection if healthcare providers are negligent. So most patients, whenever they are signing an informed consent, they would think that they are losing their rights and they might have some problems. And we need to tell them that doing or signing a consent is actually giving you rights to protect you from negligence and all of these stuff. So the core right is fundamental understanding. You must understand that you can drop out or leave the study at any time without penalty. Reasons for withdrawal: patient might want to drop out if they are not responding well to the treatment, or if the procedure is too long, or if the patient didn't like it. The patient does not have to explain the reasons. A patient have a right to withdraw at any moment. Continuous process. Communication is a key. A signature is not an informed consent. Informed consent is a process. It's not just a piece of paper. Based on communication understanding, we can reach to the patient can understand everything that it goes through the process, and then they would decide. So patient actions, the patient needs to know that they don't need to be embarrassed. Ask questions and take your time. Take the paperwork home to review it and on your own time, preferably with family or partners, and perform your own additional research. That's what we would tell the patient. And for the providers, process ensures the healthcare team remembers to explain all involved pieces of information to the patient, which is really important. Next. So your choice. For the patient, there is no obligation. If at any point you decide that the trial is not for you, you don't have to participate or sign the document. Or alternative options, you can talk to your healthcare team about what are your other options. Next. So the value of participating: generous act, 2 goals: helping yourself and helping others, and precious gift. So this is the informed consent, and thank you. That's my presentation. If anyone has any questions, I'm open for the questions.
Excellent presentation again. Thank you so much. Any questions? If no more questions, we can go to the next topic.
Okay, so the next topic will be presented by Shahd. Shahd, are you there?
Yes, just a second. I have to share my screen. Okay, can everybody see?
Yes, we can see.
Okay, I'm sorry, just a second. Okay, can you hear me?
Yes.
Okay, so hi everyone. I'm new here. My name is Shahd Madi. I'm going to be talking about, this is the topic that I was assigned, is how to create animated explainer videos for patient instruction. Okay, so I'm going to talk about how to demonstrate how to use animation tools to aid in communication and better patient outcome. But first, I'm going to highlight the relevance to the geriatric population. So why do we use animated explainer? Patient education is mostly done through pamphlets or booklets, and from my experience of working in family medicine clinics, some patients read them, some patients toss them away. So are pamphlets really effective? And so I started looking up the research, and I found a study in 2024 that shows that booklet-based education actually improves patient and family understanding compared to giving them verbal instructions alone, especially in older adults. So geriatric population or patients, they're more likely to have, just like how I think Lena mentioned before, there's the issue of polypharmacy. So we need to have clear instructions for them. They also have vision limitations. So using animated videos provides both visual and auditory input. So this makes the information easier to understand. These materials, they also help caregivers where like family members or the children of these patients or the home nurses to better support and improve the outcome. And this is the age of AI and smartphones and widespread internet access. So the way we share information is evolving beyond pamphlets. So what do you think are the common challenges in patient communication usually, especially with older people? If anyone wants to say anything. Okay, so what's
understanding the prescriptions or treatment plan?
Yes, so there's the age-related changes, right? There's cognitive decline, memory issues, hearing or vision impairment, and as Dr. Suleiman mentioned, the medical jargon that they're bombarded with. Sometimes after discharge, it's hard for them to remember the instructions. So what could be good topics that we can provide the patients with? Like, what do you think would be helpful? Do you have any suggestions?
Maybe the
Okay.
after discharge plan.
Yes, so we can include things like if I have a diabetic patient, diabetic foot care, we can tell them about drug administration. What happens if you miss a dose? What to do next? How to use an inhaler, eye drops, insulin. So this photo here demonstrates the proper ways that you can, or the proper anatomical locations where you can inject yourself, self-bathing techniques, the fall prevention information. And you know your patients best, so you would cater it to them. So when we start using these tools, you need to get your information from trusted sources. The goal is to simplify the information. So instead of me taking time out of my day and writing things down, there are resources online. So UpToDate has a new platform where it's directed towards the patients. They simplify the information. It's more, it's directed towards the average person. There's the CDC, Mayo Clinic, and I'm pretty sure there's much more that I haven't included here. So what are these tools? We have Powtoon, we have Animaker, Canva, Biteable, Movely. There's multiple. The one that I've explored is Animaker. And I'm just going to show you now briefly how to use it. I'm not sure how to share everything. Can you see my whole screen?
No.
Okay, can you see my whole screen
Now I
now?
can see you, yes.
Okay, so this is the platform. You don't need any experience in knowing how to do these things. And it's free, but obviously to unlock certain features, it costs more. It's around like $15 to $50. And I think in order to save a free video, it has to be under 2 minutes. And honestly, you don't need much more to tell your patient the information. Okay, so if I show you the website, this is the website. They also have an app. I use the AI feature. There are different templates that you can use, and the templates they have different characters for different things. And I used the AI feature, and it was very, very helpful. I made a video in less than 10 minutes. I basically summarize something and put the words in, and it made the whole video for me. And the good thing about this is that you can go back and edit the AI made video. So this is your workspace. On the right side, you have your slides. On the left side, you have the characters that you want to include or not include. You can even make them look like your patient. So then it would be more engaging. In the bottom, you have the timeline. So I can even use my own voice to explain it to them, or I can do the voice to text feature, and it has different accents, different animations, and whatnot. They also have tutorials if the time here is not enough. So I'll just show you a snippet of what I made. Can you see? Guys, can you see the screen?
Yes.
Yes.
Okay. Okay, I don't know if it's... Okay, so I'm not going to show you the whole thing, but it's about fall prevention. This is what the format looks like. It's easy. You can download it. You can send it on an email. You can send it to their phone. They can have it. You don't have to repeat the information. It's a good tool. And thank you for listening.
Thank you so much, Dr. Shahd. I was wondering if you may be just for demo, can you start a new one and just from scratch? Let's say the patient that was in the presentation earlier, a patient with congestive heart failure, or he has valvular heart disease, and they want to discuss about surgery, TEVAR, or something. So maybe you can use the AI to talk about TEVAR, TAVR, TEVAR, whatever, or congestive heart failure discussion about.
Yeah, I'm sorry. Can you repeat your question?
Maybe you can just demo. Yeah, go ahead. Sorry.
Yeah, I had a case, question in the end of my presentation about a patient who was like 83 years old, and he was getting consultation for a TAVR, which is valvular replacement. So I think the doctor just wants you to do like an illustration right now of a video about someone explaining to a patient about the risks and everything related to TAVR.
Okay. Can you see my screen?
Yes.
Okay, so you go in here, and I can pick a plain plain project if I have the time. If I do not have the time, I'll do the AI video. And then you just put in the information. I don't know the complications. If you could tell me the complications, I can type them, and it just makes it for you. And then I can go, after it's made for me, and I can go back and edit what I want and don't want. So for example, this is the slide. The thing is, my laptop is lagging. So, okay, so this is a slide, right? And there's the text here. So I can write, what is it? Complications of TAVR, right? Oh, complications of TBR. And then in the next slide, I can write it down for them. So if you could tell me maybe infection, I honestly don't know what the complications are, but assuming infections, I don't know. What else can you suggest?
That's it. That's it. Just whatever
Yeah.
text is there. Yeah.
Yes, yes. So then it's going to be displayed in an organized manner for them that is easily digestible. And I can even take this out and put the character and make the character speak for me, or it can demonstrate the information for them. There's also different transitions and different scenes, and yeah. I don't know if that was enough.
Yeah, yeah. So I just want to show the other fellows that it's doable, it's simple, and
It's
you
very
need,
simple.
yeah, you need just to have an idea about what you want to educate your patient about. This
Yes.
patient, in the case, maybe they want to know what the risk of the procedure. So you can get that information, put it in a text. As you mentioned, you can add a character, and then the character will explain that. The text will be read, so it will be converted from text to audio. So the patient will look at the character talking, and then the text will be displayed and so on. So it's going to be an active kind of user-friendly approach, as if you are sitting in front of the patient and explaining things, but you are not doing that yourself. Thank you so much.
And it's extremely easy. It took me less than 10 minutes to make it, so it's not very hard. It looks complicated, but it's not. And even though they have tutorials, if you have any questions or how to do certain things, they have tutorials and it's readily available.
Excellent. Thank you so much, Dr. Shahd, for great presentation.
Thank you,
Any
Dr. Shahd, for your presentation. If anyone has any questions for Dr. Shahd. If not, we will proceed to our next presentation, which will be presented by Dr. Muhammad. If you can please take over. Dr.
Hello, everyone. My name is Dr. Muhammad Makar. Can you all hear me?
Yes, we can hear you loud and clear.
So I'll be discussing about an application known as Miro. So I think you can see my screen. So basically, Miro is a whiteboard. So here you can post whatever you want to talk about. If you have any topics, you can discuss. You can post it here and share it with others. Just hold on. Okay. So how do you do this? First, just open to the website miro.com and then just make an account. It won't take much time. Then you will be presented with your own whiteboard like this. So basically, with this whiteboard, you can share with others. You can have others join with you. If you click the share button here, it will show you a link. You can copy this link and share it with certain people so that they can join you at the same time. And what can you do? What's I mean, you can use it actually for a lot of things. If you have a project, for example, and you want to work together, you want to start with, let's say, you want to do a study, for example. So with Miro, you can do a lot. You can do present. You can do flow charts. You can do flow charts. Especially, they're really good at making ones. So you do it manually. You click here on this side. You can see what shapes do you want, and let's say if you want a square one, okay, you started with this box. Then if you want to extend it, you can just press this button here, and then you can have another one. If you want to branch, you can also press here, and you can have another branch. So you can make your own flow chart. To navigate, it's easy. If you just use the right click button and hold, then you can just move around. Okay, and then you can format and edit as needed. Another thing, another good feature here is that you can use AI if you want to generate your own flow chart. For example, I wanted to make this flow chart about the BLS, basic life support. So if you can see this icon, create with AI, if you click it, it will show you what do you want to make with AI. And what format what diagram would you want? If you want a flow chart or a diagram or a mind map, let's take a flow chart, and then you can ask, let's see, make a flow chart describing the process of baking a cake, just as an example. Then you can press enter, and then it will start generating. So we have this basic flow chart. You can see starts by gradient, preheating the oven, mixing ingredients, then pour batter, and so on. And then if you, for example, you make a chart, then you want to add, you can just click on it, and you can press this blue button, and then you can, if you want to add any extra details, you can mention it here. So this tool also, you can use this also as a teaching as well. Let's take this flow chart which I made earlier about BLS. You can just make it as a quiz. For example, you can delete this, make a question mark. Then if somebody, then you can share this and share the invite link. Then somebody can join you and be live at the same time. Then you make a live quiz. Let's say and ask, for example, what does this point here refers to in this algorithm regarding basic life support. So the other individual can actually modify it and write. Okay, and they can write they can write the answer. All right. So this is basically it. There are other features, but they're mainly paid. So with the free ones, you can do this AI generated. And let's say again, if you have a big project, you can, for example, let's take about, let's do a research example. Okay, so let's again use the flow chart and say, and ask, make a flow chart describing the parts of a research project. And then we'll be generating it. So we have this basic information. So let's say that we already have an idea. So we can just modify here and say, let's say we're going to make a research regarding relationship between vaccine and autism. Okay, so we have this as our research question. Somebody else, when you share the link, can post, for example, a sticky note here and say, you can suggest more clarification, for example. And let's say you have, you want to add something else, you can just click here, this blue box, and you can add another tab and write if you want to write something else extra. So basically, Miro serves as a whiteboard where you can work together as a research. For example, if you have like 4 or 5 individuals, one can make the board and then they can share the link so that they can all be working in the same board at the same time. As well as if you want to teach a particular topic, you can also use these diagrams to explain what you want to explain. You can also use AI to help to generate for you these flow charts. And you can also name your whiteboard. If you just press here, you can rename it as you wish. Okay, so that's basically what I have. If you have any questions regarding Miro, I'm glad to help you. Thank you very much.
Thank you so much, Dr. Mohammed. Any questions or any comments?
Hello, I have a question. At first, thank you for the presentation, and thank you, Dr. Nader, for your time. I want to ask if I want to use this flow chart, for example, in my presentation, is there any way to make the display fit within a presentation, or can I copy it as a chart, not as a link? Does it have this character, the Miro app?
Yeah, just let me share my screen. Okay. So if you want to mark, just hold on, because it's a bit, there's a lot of things here. So just wait, just wait. Yeah, okay. So let's say that you want to carry on this, let's say you want to take this flow chart. So you can just mark it. Okay, then you have in more, you can copy as image, for example. So if you copy it as image, it will be, you can save it as an you can save it in your desktop as a PDF, and then from there you can, or when you open your PowerPoint, you can just paste it over there.
Okay, appreciate it.
No, thank you. Any other question?
Thank you, Dr. Muhammad, for your presentation. And by that, Dr. Nadir, we finished presenting the topics for today. So if anybody has like any comments or any questions for all the group, we're here to help.
Thank you all. Or if there is any updates, anyone with anything to share, what are you up to? If you are involved in a project or you have ideas or some suggestions, please go ahead. How is the application process? Any one of you applied and received any invitation? Anyone had interviews or will have interviews like invitations?
Hello, Dr. Nader. I did have 2 interviews, alhamdulillah, and they are in December and January. One with University of Central Florida, Ocala, and the other one with Holy Name Medical Center in New Jersey.
Excellent, excellent. Congratulations. And I hope you have some time to prepare. If you are planning to come next week, we'll have one of the seniors who match to neurology program. So she will come and share her tips. Her name is Rufaida, Dr. Rufaida. She is in upstate New York. So if you started already practicing a mock interview, that would be great. If you need more tips, maybe join us next week and hopefully she will give us some tips. Congratulations again.
Shukran. Thank you, Dr. Nader. Really appreciate the efforts
Thanks.
from the group. Thank you. Inshallah, we'll be at that mock preparation.
Did you do any mobile application? Or are you involved
Yes,
in any?
yes, I did. I did try using it. It's very helpful.
Excellent.
I did use it, and we are using it. Me and my group that we are preparing together.
Yeah, because most likely they will ask you about using AI, using mobile app, any innovation about this program. So just be prepared, and if they didn't ask, lead them to ask you. Thank you.
Inshallah. Thank you, Dr. Nader. Thank you for all of the opportunities.
Wish you all the best. Anyone else? Anything about the program itself? I just want to update you that we submitted our application to the Michigan State and we have approval now. So we are recognized as an organization, non-profit, as a tele-geriatric research fellowship program. And we are working with the Combined Research Foundation. So the next step, we will get an ID from the IRS so that if we get some funding, we'll use that number to show tax papers and any reports in the future. So just to keep you updated. So we are going in the right direction, and any suggestions, questions, comments, let me know. Any ideas about improving this program, this fellowship, anything that we can add, we can change to improve? Any suggestions from you guys?
Maybe advertising more in socials so more people can join.
Sounds good. I think now we can do that because in the past we were not legally in a body, so it's just word of mouth that we are trying to help each other. But now I think we can formally build a web page presence in LinkedIn and other platforms so that we can advertise more. Thank you so much, Dr. Shahd, for that. Yes.
If I have just one comment, if it's possible just to get like more guidance when you first join the program from the seniors, to just get an idea, because at first you kind of lost until you get your group, until you start a project. So just like more guidance from seniors, fellows who've been in our shoes and who've done this before, and just, yeah, that's it.
Sounds good. Thank you so much for your input.
Also, the process of joining a research project or any project, I'm a kind of new, not so new member, but I found it's a little bit difficult to find a group to join. Yes, the groups are on the app. I tried to send an email to the leader, some of the members, but most of the time no one will reply to me. So I don't know how we, as a group, we can fix this and make it more easier and more accessible, especially for the new members.
Sounds good. So we'll look into that and see how we can improve that as well. Thank you. Anything else? So again, if you are already in a research project, that's well and good. If you are able to get involved in creating, developing, or making a mobile app for your patients of interest, if you are in internal medicine, family medicine, pediatric, neurology, something like that, so that you can improve on your application, your CV, and when you have an interview, most likely they will ask you about these new things that currently in the like media, like AI, anything that you can help your patients with, any tools that can be of help to the patients. Remember, the goal is to help your patients avoid rehospitalization, for example, patients with congestive heart failure, how to keep them out of the hospital, asymptomatic, and so on. So just remember all this when you apply to programs. You think about what they value, what's important for them, what's the impact, how they get their patients like rounding at the hospital, minimizing rehospitalization, and so on. So just to understand the healthcare system that you want to get involved in. If no more questions, I'd like to thank you all, Dr. Suleman, and your team, all the presenters from today or who attended today's meeting, and those who will watch the recording in the future. Thank you so much, and I wish you all the best. And if you have questions, please call or text me. I'll be happy to answer. You can email me as well. Thank you. Have a wonderful day or have a wonderful night. See you next week,
Thank you,
inshallah.
Dr. Nader. Thank you very much.
so much.
Thank you, Dr. Nader.
Thank you, everyone.